Okay, I'm going to go ahead and get started. I know people joined in the first couple minutes, so welcome. Thank you for joining us for our mental health support for the workforce. A lot of you have been with us as we've done this every 2 weeks for the past several months, so I appreciate you coming, and for anybody who's new, welcome. Reminder, this is Zoom, so we'd ask you to just turn on your cameras if you're comfortable. We hope you're eating lunch, so no problems. Unmute yourself, but if you have a question, it's okay to go ahead and unmute. And then feel free to use our chat box to introduce yourselves, tell us where you're from, and to ask any questions throughout the presentation. And then we'll tell Dr. Everly those questions, and we'll make sure we get them answered. So you all know what I like to say. We like to create friendships here. This is a network, and so be vocal, and please make sure that we know you're here. Tanya and I are your facilitators for today. So Tanya, I'll have you say hi.
Hello all, glad that you're here and really excited to hear from Dr. Everly today. It's great to be getting this expertise from a nationwide perspective on this important topic.
Great. Thanks, Tani. And as a reminder, I always have to say this, ICSI has strong antitrust policies, so keep that in mind as we have our presentations. And just a reminder for the upcoming webinars, we have a webinar in 2 weeks with Dr. Susan Scott from the University of Missouri, talking about the program that they have created there for worker support and well-being. So we're excited for that. That will be back to Wednesdays, so we hope you will join us then. And then 2 weeks from then, on September 9th, we have a Mount Sinai presenter that we're really excited about, Dr. Jonathan Ripp. So we'll send out reminders, don't worry, and it's on our website. Our playbook as well is on the website, so go visit that. We'd love your input. We want to add to it. It's a work in progress, but please go to it, check it out, and give us your feedback, and we hope it's useful to you. And with that, I would like to introduce our presenter, Dr. George Everly from Johns Hopkins. We are so excited to have him join us. He is a national and international expert on resiliency. He has led the first responder echo done by New Mexico, and that's where I actually heard him present several weeks back, and then told Tani, we have to get him on ours. So has done so much work in this area over the years. As a professor at Johns Hopkins, has worked with the CDC, is a co-founder for the International Critical Incident Stress Foundation, so has worked a lot with pandemics and other international crises that have happened, and has wrote a lot of textbooks and professional papers on psychological first aid, resiliency, post-traumatic stress disorder. I could go on and on. He is our resiliency expert, and we're really grateful that he came to talk to us today. So without further ado, Dr. Everly, I'm going to turn it over to you.
Well, thank you very much. I appreciate the opportunity to spend some time with you today. Just to, as my son, the attorney, would say, in the spirit of full disclosure, I do get royalties and speaker's fees for some of the things I will be discussing today. So I'd like to spend some time talking to you about creating an organizational culture of resilience. We spend, in theory, about 1/3 of our adult lives in the occupational organizational environment. So whether that is toxic or whether that is supportive matters. So that helps us understand the importance of the organization and its culture on individuals, I guess. But organizations are also part of communities. And oftentimes community health is tied to organizational health. I learned that spending my summers in the Deep South, where my mother's family was from a mill town, they used to call it, and it was basically a one industry town. So as the organization went, the town went. So organizations are important parts of our lives. What do we know about them in terms of the interface with our mental health? So organizations most likely to survive and actually prosper in times of adversity, according to the Institute of Medicine, possess a resilient culture. Former Assistant Surgeon General Brian Flynn said, the only way to change an organization is to change its culture. Certainly right now, we are dealing with unprecedented stress, change through the COVID. There's not a roadmap for this. Now, this ain't my first rodeo. This is actually my third pandemic. First was SARS. I had a professorship in Hong Kong and later worked in Singapore and did work with Ebola. But I will tell you that this one's different. The impact is far more severe, probably goes without saying. It's qualitatively different also. And the implication is for individuals, for families, and of course for organizations. So what is a resilient culture? Well, it's an environment where human resilience, in other words, the ability to withstand kind of an immunity or rebound from challenges and adversity, is not only fostered, but it's in the core fabric itself. And that's important. It should not be tied to one particular leader, a CEO, a division director. Rather, it should transcend those people. So when those people come and go, as they invariably do, the culture should stay the same. That sounds like a bit of a reach, but work with me here. I wrote a book a number of years ago where I interviewed resilient people. I interviewed people who had survived catastrophic physical medical illnesses, interviewed politicians, actually interviewed two people who ran for president in the last presidential election, interviewed professional athletes. And one particular athlete told an interesting story. And I said, any particular one point of your career stands out? Now, I had known he had been on 2 World Series championship teams. I thought he was going to say something to that effect. And he said, well, I was 19 years old and drafted by America's sports team. At the time, it was the New York Yankees baseball team. And he said, I had a fastball and I had great control, but that was pretty much it. So my first day pitching out for real, I cannot throw a strike, he says. Just the plate was eluding me. The center fielder stopped the game. Now, normally it's the catcher or the manager. No, this was the center fielder. Stopped the game, ran into the mound. And he said it was a rare day for this center fielder because he was actually sober. I said, I need to ask you about that a little bit later, but he said, the center fielder said to me, what's the problem? And I said, the pitcher said, I guess I'm nervous. And he said, the center fielder said something to him that changed his life at that point. Center fielder looked at him and said, you're a New York Yankee. Now play like it. And don't make me come out here again. And he went back out in the center field. I said, what happened? He said, I started throwing strikes. We won the game. I said, what? So did he scare you? Did he intimidate you? No. He reminded me I was part of something greater than myself. I was one part of a bigger mosaic. I was trying to win the game single-handedly. I was trying to strike everybody out, and in the effort, wasn't striking anybody out. I failed to realize that an organization, a team, is made up of people, and how they relate to one another is the imperative. I had 8 of the best people who have ever played the game of baseball behind me. All I had to do was play my part, which was put the ball in play. I didn't have to strike people out. So the culture, the organizational culture of resilience is defined by cohesion, collaboration, pride in being that New York Yankee or whatever. Colleges certainly get a lot of traction out of that, don't they? Be proud, school spirit, buy a school t-shirt, wear a school hat. And of course, the alumni associations, how many emails do you get from them? Proud to be a blank, a Terp, a whatever, a hurricane, if you're from Miami. So the organizational culture is one where growth is promoted, risk is encouraged because there is a backdrop, someone has, and the stars are the limit. This picture is actually the Burj Khalifa, the tallest building in the world right now. So the IOM report went on to say organizational resilience can be fostered through something called resilient leadership. Now, the book that I wrote called Resilient Leadership was kind of a unique one. It was actually the idea of people in the government of Hong Kong, where I'd been working in the hospital system. They had over 40 hospitals, and I chaired one of their committees and was working with them system-wide. And they said, we'd like you to teach a class on leadership. And I said, well, I've got a couple of degrees in business, and that was my minor in business school, but I don't do that anymore. And they said, no, we were preparing for the Beijing Olympics. We'd like to train our managers to be ready for the unexpected, if you will. And I thought about it, and I thought, well, leadership, you go to military academy or business school. That's where you learn to lead. Let's try leadership from a different point of view. Let's teach leaders to create a culture where not only they are resilient, but most importantly, those who follow are resilient, because that is the fabric of the organization. Douglas McGregor changed the world in business school when he wrote his 1960s book, The Human Side of Enterprise. And he argued quite cogently that the most valuable resource any organization has is the human resource. So here's a quick quiz for you. The theory is one thing, but I'm also empirically oriented. So wanted to see what the most important leadership characteristics might be that predicted not only overall effectiveness, but crisis leadership. So we have these 9 variables. Take a look at them. Tell me which are the top 4. Which 4 predict overall, interestingly enough, overall effectiveness as a leader, but more importantly, crisis leadership? Is it communications, economic management, ethics, interorganizational relations, administrative skills, relationship with oversight and collaborative groups, vision, optimism, policy of fairness and equality, or performance? So this is a study that was repeated 3 times over the course of 17 years. And the answers are basically what I call strength and honor. Now, you didn't see those words on those previous slides. I stole this from a movie called The Gladiator, starring Russell Crowe many years ago. He won an Academy Award for it. But the answers that came out of the research were 4 from the previous list. And in fact, if we were to go back, the answers would be 1, 3, 7, and 9. And I just simply rephrased them a little bit. So how do leaders create resilience in those who follow? The wise leader is not the leader that does everything him or herself. The wise leader is the person that delegates and builds strength through the organization. That organization and that resilience then becomes that leader's legacy. So optimism, positive vision, bold, decisive action. Have you ever worked for a leader who couldn't make a decision? Honor. So that was strength. Honor is integrity, ethical behavior, perhaps following a moral compass. And lastly, open, effective communications. Here at Johns Hopkins, we have our little alliteration. We think of open communications as truthfulness, transparency, and timeliness. Rudy Giuliani, forget what you think about him politically right now. He was the mayor of New York at 9/11. I worked for him for roughly 3 years. The man was an absolute crisis management genius. He did amazing things. He said, leaders need to be optimists. Their vision is beyond the present. We go back to roughly 300 BC. Between 300 and 500 BC it's hard to really. There were actually a lot of treatises back at that time called The Art of War. Sun Tzu wrote several of them. And he talked about decisive action. He said, be decisive. Vacillation saps the strength of any army. If action is necessary, make it swift. Act boldly. No one benefits from protracted conflict or ambivalent leadership. It just so happens that we are living in a very interesting time. So you may want to resist the temptation to assess your local, community, state, or national leadership on these 4 criteria that I'm about to show you. But the temptation is there. Leaders must avoid paralysis by analysis. When I talk to leaders and I say, why didn't you act? The most common thing I hear is, we wanted to make sure that our actions were at the right time and were the right actions. We waited for that moment of absolute certainty. How many times in your life have you waited for that moment of absolute certainty and it never came? But what did happen is the opportunity left. George Patton, arguably called the greatest general of World War II, said the only failure in leadership is the failure to lead. Our 4th factor was integrity, and this I stole directly from the movie The Gladiator. What you do today will echo for eternity. I think sometimes leaders get fixated in the moment, and they fail to understand that this is their legacy. Warren Buffett on integrity and looking for people to hire. You look for 3 qualities: integrity, intelligence, and energy. If they don't have the first, the other 2 will kill you. So what should leaders do? There's actually been a number of papers, some written in the Harvard Business Review, on the importance of integrity and trust in organizations. And one particular author studied trust in organizations and found they were more productive, job satisfaction was higher, and something else was kind of important. Their attrition rates were lower. When someone leaves the job, especially a middle manager or someone in the C-suite, it is remarkably costly. It's been argued that to replace a frontline worker roughly costs 4 times their salary. A manager, 10 to 15 times their salary. Somebody in the C-suite, anywhere from 100 or more times their salary. So keeping people is important. Honesty instills a sense of safety and trust. Leaders are sometimes afraid to communicate bad news. The only thing worse than communicating bad news is not communicating. And the only thing worse than not communicating is communicating but being less than truthful about it. Now, people will delay their communications. Again, waiting for that moment. They don't want to say something that is wrong. What is interesting, though, is when we talk to people, we ask them, what's the greatest sin of the leader in communication? Is it not communicating, or is it communicating something is wrong? Invariably, people say, we want to know. And if it's wrong, correct it. People are remarkably forgiving. But when you don't communicate, sometimes people's fantasies run wild. Like, well, you know something, you're just not telling us. Follow the law of morality. Regard your soldiers as your children, and they will follow you into the deepest valleys. So I created this simple moral checklist. When acting to benefit yourself, and I say this to the leader, simply ask the following: am I being deceptive? Does my action hurt anyone? Would I be uncomfortable if those I love learned of my actions? And would I be hurt or angry if somebody did this to me? If you score on any of them, I say to them, maybe you want to reconsider your decision. Now, sometimes I'll get some smart people who say, well, you know what? I didn't really lie to people. I just didn't tell them the entire truth. And I said, if your intention was to deceive, it was a lie. They don't like that. No such thing as an information vacuum. The leader is not communicating, then someone else is, usually the most distressed. Again, very smart people. They delay information. Why? They say, I don't want to get something wrong. They probably could have gotten away with that 50 years ago. Not now, not in the age of social media. If the leader is not speaking, someone else is, usually the most distressed, with the fastest thumbs and the widest Twitter feed. Not a formula for success. As William James, the founder of American psychology, he spelled his name William with 2 L's, not 3. The deepest craving of human nature is the desire to be appreciated. Show people they're appreciated. Show them they're part of the team. If you don't, the minds kind of run wild. Listen to the whispers so you can avoid the screams, I say to leaders. American Indian proverb. Abraham Lincoln, every Tuesday, would open the White House. Anybody could walk in off the street and chat. His bodyguard one time said, Mr. President, you're wasting your time. Why do you do this? He said, on the contrary, of all the time in the day, this is the most valuable. I get to listen to what people really think. As Calvin Coolidge, Calvin Coolidge isn't known for much, but he has some really pithy one-liners, and this was one of them. No man ever listened himself out of a job. Some of you may be aware of the really powerful, I thought it was great research coming out of family therapy, where when you took a look at couples, if they didn't say 5-to-1 ratio, 5 positive comments to 1 negative comment about one another, when just allowed to talk free form, they found that the relationship did not last very long. So people that were married got divorced, people that were engaged never got married, and people where they were dating just never went beyond that. 5-to-1 positive ratio. So somebody got the bright idea. Maybe that extends not just to significant other relationships. Maybe it extends to the workplace as well. And they found the same thing. The 5-to-1 ratio was really important. Leaders needed to communicate 5 positive messages to everyone that was negative. Are there sins of crisis communications? That's our 4th variable. Remember, open, honest communications? Yeah, communication information is fact when in reality it's speculation. All you have to say is speculation. All you have to say is what we believe now. This is our understanding currently, but that may change. Delaying communications for that moment of absolute certainty. Trying to please everyone. Failure to communicate, and lies and half-truths. So let's recap. What is an organizational culture of resilience? Why are we interested in it? We believe that organizational cultures of resilience predict sustainability. And in fact, there is some evidence that some organizations in times of crisis, those organizations are resilient, actually grow in crisis. Part of the reason for that is their competition is wiped out, and they end up with larger market shares. I was actually given quite an honor a few years ago. I was asked to give a talk to the Harvard Business Week. It's for finance, the meeting is Davos in Switzerland. For business, it's the Harvard Business Week. This particular year was in Sao Paulo, Brazil. And they invite the CEOs from billion-dollar international corporations. And I was asked to give a talk on resilient leadership. And I thought they would be less than interested. These are the cream of the crop of international leaders. What is it that I could possibly offer them? And yet what I showed them by taking a look at their stock prices, because their jobs are dependent on their stock prices, I showed them when they handled crises well, their stock prices dipped initially, but then went up, and they actually gained market share. When they handled crises wrong, their stock prices dropped. And in one case, the price had stayed low for 15 years. Of course, they changed CEOs. So the corporate organizational culture of resilience is not just instilled in one person, the leader. To be sustainable, you want it across leaders. It must be in the fabric. How do you do that? How do you do that as a leader? We actually wanted to change the culture, and I've been asked actually to consult with a number of federal agencies. And they say, how do we change our culture? Do we train everyone to be everyone in the C-suite, so to speak? No, actually, I'm going to give you guys a briefing. But the people I really want to change, I want to change frontline managers because they are really the culture. Those of you in healthcare and in hospitals, what's the culture? Where does the culture come from? Believe it or not, I think it comes from frontline managers. They shape the culture of the healthcare institution. So what we did in various organizations is train all of the frontline managers in resilient leadership skills, and we also taught them this thing, psychological first aid. Did you ever notice if you're a manager that sometimes people that work for you come to you with not just work-related issues, they sometimes come with personal ones. And to think that our lives are two separate silos. One is our personal life, one is our occupational life. That is an illusion. There is this great term. We used to use the term work-life balance. COVID taught us there is no such thing. It's work-life integration. But it's always been work-life integration. COVID just hit us over the head and put us in quarantines where we really had to confront it. So the four factors then, if you remember, vision, optimism, decisiveness, a sense of a moral compass, and the ability to communicate, not just in good times, but in bad. In a few minutes I have remaining, I want to share a little bit about psychological first aid. It is relevant to our discussion and beyond. It's relevant to our discussion because I believe every manager should be trained in psychological first aid, every frontline manager. But now, especially in COVID, we are seeing, especially in healthcare institutions, the need for some sort of peer support, some sort of psychological support. Now, many organizations have EAPs. Many healthcare organizations have departments of psychiatry. We have found that those things, frankly, in and of themselves are insufficient. Many people will not use those services for a myriad of reasons I won't enumerate. They can be, nevertheless, very important parts of a continuum of care. But what we have done at Johns Hopkins, and I believe you had Albert Wu talk about the RISE program at Johns Hopkins that we set up about 6 or 7 years ago. But I believe that peer support programs are important in every organization. But people need training. What do we train them in? Who should be trained? Anyone can be trained. We have very insightful leadership in our Department of Psychiatry. The vice chairman, when we were talking about expanding our peer support program, the vice chairman of psychiatry said to me, you know, one of the things we have to do is train our psychiatrists to practice psychological first aid, first and foremost, and psychiatry, secondly, during this COVID, which I thought was remarkably insightful. Psych first aid is a form of psychological crisis intervention. If you're wondering about the history of that, it goes back to World War I, largely. The emerging standard of care in healthcare and especially law enforcement, I would argue, is peer support. The caveat is they will always need some sort of formal mental health oversight. That's the imperative. All frontline supervisors should be trained in psychological first aid, and that is now the mandate at Johns Hopkins Medicine. PFA has been recommended by World Health, United Nations, American Psychiatric, American Psychological, Red Cross. The list goes on and on. first and foremost favored intervention during or immediately after a crisis, according to NIMH. So what is it? Is it holding someone's hand psychologically? Maybe you start there. But think of it as compassionate and supportive presence designed, and this is important, to stabilize and mitigate acute distress reactions. And as indicated, facilitate access to continued mental health care. Notice, please, the conspicuous absence of the terms diagnose or treat. And that's why I say in the law enforcement industry, it is the standard of care for psychological support. We train officers and agents. We train nurses and techs and security personnel in healthcare organizations. The evolution of the model that we've developed here, I'm showing you basically a quick pictorial, started in the early 90s when I was asked to teach at the behavioral science unit at the FBI Academy. At the time, if an FBI agent discharged his or her weapon in the line of duty, on average, they only had 4 more years left to their career. It did not matter where they were in their career. On average, that event was traumatic enough that it would dramatically shorten their career. And it was decided that that was unacceptable and something had to be done about it. One of the things that we began to do was develop kind of a peer support approach. In 1992, largely seen as the year of the founding of the field of disaster mental health, largely because of the initiatives of the American Red Cross, we had decided, we had recognized that there was always a mental health consequence to a disaster, and that the psychological casualties would always be far greater than the physical casualties, on a multiple of somewhere between 4 and 50 times more psychological casualties than physical. After the first Gulf War, I was asked to go to the country of Kuwait and train their doctors in how to treat post-traumatic stress disorder. We ended up setting up, as far as I know, the world's first resiliency-based clinic. And while treating both psychotherapeutically and pharmacologically post-traumatic stress disorder was important, we also found that psychological first aid was an integral part of healing communities. Kuwait was the only place in the world I've ever been. I've been to 39 countries on 6 continents just to see every imaginable type of disaster. It was the only place I had ever been where they actually had more resources than they needed. Normally you think of a disaster, you're working with very, very few resources. They had more money, more physical infrastructure than they needed. Top line everything was rebuilt within 2 years. I gave my last talk to the Kuwaiti parliament, and I said, your country will never recover until your people recover. Simply throwing money at a problem, it doesn't work. We ultimately ended up developing what we call the Johns Hopkins Rapid Psychological First Aid Model. Originally, it was designed specifically for disasters. We received CDC funding to specifically do that. But we then expanded it and we brought it into the Johns Hopkins Hospital and other hospitals in the system. There are many, many models of psychological first aid. I teach not just in the School of Medicine, I also teach in the School of Public Health. Public health perspective is very different. We look at saving lives, promoting health, millions at a time, so to speak. We look at the macro, the big picture. So we modified the rapid model so that it could be used not just as a tool to kick the can down the road. In many instances, psychological first aid basically stabilizes and then refers people on. What happens if you refer someone to the emergency department and the emergency department is underwater or it's on fire? What do you do? So from a public health standpoint, we had to be mindful that the psychological first aid intervention might be the only intervention. From that point of view, we ultimately developed the notion that we could approximate universal mental health care. if we could go into communities and train people who were so inclined and had an emergent background or mindset to do psychological first aid. An interesting thought. A little help, rationally directed, purposefully focused, at a strategic time is more effective than extensive help given in a period of less emotional accessibility. What's fascinating is that was written in 1965. 2011, a paper was published that found in the acute phase, post-disaster, workplace-based crisis intervention was found to actually be superior to multi-session counseling. Almost counterintuitive, you would think. Well, how long does it last? 20-year longitudinal study says it lasts at least 20 years. At first, that takes your breath away. You say, oh, that can't be. But wait a minute. Have you ever heard of people at a strategic moment in their life's trajectory make a left-hand turn that didn't turn out well for the rest of their lives? Or maybe made a right-hand turn and like, oh my golly, that was lucky, but my whole life is different now. I will suggest to you that there are mile markers on this journey we call life. And at certain points, strategic decisions dramatically shape the rest of the trajectory, the rest of the journey. And crisis intervention can be, I think, a helpful process. So we actually, one of the problems with crisis intervention is hard to do randomized controlled trials. So most of the studies on psych first aid are quasi-experimental design, survey self-reports and the like. We have, however, done 2 randomized controlled trials, and we found that we were able to impact positively anxiety and depression. Then we took it out into the field. We took it out into the community. We wanted to build community resilience, and we were able to do that as well. Last point, just throwing psychological first aid out in the organization or community can be effective, but rather we would also like to see a complete continuum of care. In this particular study, the continuum of care referred to as critical incident stress management was employed in New York City, workplace-based interventions after 9/11. What you see in the parentheses are effect sizes, basically the power of the intervention. So just to give you an idea, if an effect size is a 0.1, 2, or 3, it's considered low. If it's 0.7 or higher, it's considered large. Just metaphorically, the difference between a low effect size and a high effect size would be roughly the difference between someone who is 5 feet tall and someone who is 7 feet tall. So it is considerable. We took a look, and I'm sure Dr. Wu shared this information with you. Based on the RISE program at Hopkins, it was estimated that we could save almost $2 million a year because of our peer support program. So the approach that we take at Hopkins Medicine, we require now mid-level managers, frontline managers to go through resilient leadership training. Policymakers are given briefings. We establish a peer support program. We have an EAP. We blend it in with the spiritual care chaplaincy services. We have wellness services, and we have a department of psychiatry. I will pause there, Jody.
Fantastic. Thank you so much. A lot of great information. I have a few questions. I'd ask people to chat in some questions, but I'm going to just kick it off if that's okay. So on the psychological first aid, once, workers are trained, what's the follow-up? How do you follow up those workers to see how they're using it, or to staff to see if it's been beneficial? So what's the kind of cycle run to see how it's impacting staff?
So our RISE program, and I'm sure Dr. Wu explained, is a volunteer program. They have periodic meetings. They have periodic update trainings. So everyone is basically kept. What we try to do is create a cohesive, collaborative group, even within the RISE program. I am one of the supervisors for the, I won't tell you which one, but for a high-profile federal agency. So we have 2 psychiatrists and myself who oversee the program. We have 40 agents who are peer support agents. We have a complete continuum of care. We have the ability to send agents anywhere in the world, literally on an hour's notice. We'll put them on a jet. And they will be in the field. They've been trained in basic and advanced psychological first aid. Here's where the oversight comes in. Every time there is a dispatched agent or 2, myself or one of the 2 psychiatrists gets a call, and we say, they say, this is what's happening, and we provide basically anticipatory guidance. Once they're on the ground, they report back to us what they see, and then they're pretty much, they've been trained to operate, not operate physically, obviously. They're to provide psychological first aid. Most of the time, we will follow up and say, how's it going, or how did it go? Every once in a while, it's rare, but every once in a while, they'll say, this one is a challenge, can you come out here? So one of the 3 of us will now get on a plane and we'll fly out there. We then have the ability to hook someone up with local mental health resources. We have the ability to bring them back to Johns Hopkins for outpatient therapy. We also have the ability, if requisite, to bring them into inpatient, step down, outpatient, and then return. The agency, which is its headquarters is in Washington, D.C., is basically very supportive. And so what they do is they will take that field agent and reassign them, the one in need, to the Washington field office or headquarters. So they can, and Baltimore and Washington is only 45 minutes away. So, so they can see us for as long as necessary. One of the things that we do is we also provide twice a year updated training for the peer group. Part of what we will do is we'll provide people, well, has the science changed? What has the research told us? What we will also do is we'll do case studies. Let's take a look at our interventions over the last 6 months. What went well, what didn't go well? How about a high-profile intervention that wasn't ours, a bombing, a terrorist attack, something that wasn't ours? What would we do? So we do tabletop exercises. So we keep people very much involved.
That's really helpful. Thank you. And I know a lot of organizations on the call are using PFA, so please chat in your questions. I'm going to just roll with one more question that I have about communication. I really appreciated the kind of talking about communicate, don't wait for finality because then it's too late. And I wonder, how do you handle the challenge of people maybe not always being forgiving? So I'm thinking about masks, right? And how the messaging around masking has changed so much of we don't need to, now we do. And then I think it's been a struggle for, and maybe more the lay public as opposed to healthcare workers, but how do you navigate being really clear that this is the best we know at the time so that people don't get angry or, feel like things are constantly changing?
You can't control other people. People are going to feel angry anytime you take something away from them or provide an inconvenience to what has become a convenient lifestyle. But I like what Dr. Fauci said, because he did basically 180 degree on the mask issue. And he said, I don't regret it. At the time, this is what we needed. This is what we said. This is what we believed. We learned something different later. We changed. I think the best you can do, and there are no guarantees, is to simply say, when you're saying it, this is what we believe now. We reserve the right to change our mind. And that's, I don't know. I mean, you can't make anybody like you.
Right. Yeah, no, fair enough. Any thoughts from the group? So, Dr. Either, do you want to, you want to unmute and ask your question? I'm seeing it here in the chat.
Sure. Thanks, Dr. Everly. That was very insightful given our current situation. This isn't meant to be a gotcha type of question, but it is a concern I have because people use the concept term resilience a lot. And it's typically discussed as in returning to a prior, better state, golden age thinking, make America great again, whatever we want to say. But that presumes that the prior state was perhaps more a better state, and we can idealize it. So I was wondering, you talked about organizational change, and how do we think about resilience in the context where the prior state may not have been a better state or one that we would want to aspire to?
Well, it's a great question. I don't see it as a gotcha question at all. I think it's an insightful question. So my native language is English. I am not fluent in any other language that I would like to advertise, at least. So I'm stuck with the denotations of English. I rely on the Oxford Dictionary, right or wrong. So when you look up resiliency, it means to bounce back, to rebound to a prior state, not necessarily a better state, but a prior state. So of course we are reminded of the Nobel Prize winning work of Walter Cannon, who coined the term homeostasis. The balance, that baseline, as you know, Dr. Eater and others, that baseline will be variable. It will be idiosyncratic. For some, it's very high. For some, it's rather low. But what the crisis has done is wherever you started, it knocked you down. I think there is value to return to that homeostatic baseline. It means nothing, it is in no way prohibitive about improving, however. So if we first start with the correct use, according to Oxford Dictionary, of the term resilience, it simply means to bounce back to your previous baseline, good, bad, indifferent. However, the term has been abused in the psychological literature, so now it refers to withstand, immunity. In other words, the adversity in the denotation of crisis means it knocked you down. It must if you're going to rebound. But now we've extended the definition, muddied the waters, admittedly, by saying, but sometimes this resilience thing is prophylactic, it's preventative, it keeps you from falling down. I don't like that. I would call that resistance, not resilience. So what we did 2006, out of the Department of Psychiatry, we wrote a paper trying to clarify the morass around the connotations and denotations and said, look, and for some reason we seem to get stuck in alliterations. So we said the withstand, we will call that resistance, kind of a psychological immunity. The rebound, we will call resilience, and treatment and rehabilitation, we will call that recovery. So for whatever it's worth, we acknowledge a lot of what you're saying, but I want to take it one step further because you said return to what may be a better state. Well, I was teaching in Hong Kong, and one of my students came up and wrote in Mandarin. And he said, so what do you think? And I said, the only thing I really think is I don't read Mandarin, so you're going to have to translate this for me. He seemed a little disappointed, but he said, well, it's the word crisis. It's two symbols. And I said, okay, I'm happy for you. And what's the punchline? Well, he said, if I literally translate it, one symbol is danger, the other is possibility. And he said, those who grow from crisis are often the ones that see the danger as possibility. Most people see the danger as danger, and it's paralyzing. So what I look for in a leader is someone who says, yeah, this is bad. This may not even be fair. But the only thing worse than what's going on is to sit here, lay here, wallow in self-pity and immobility. Perhaps there is an opportunity to grow beyond this. And those are the people that ultimately I studied, Navy SEALs, athletes who had remarkably long careers. I interviewed Cal Ripken. What a fascinating behind the story he told. Again, seeing opportunity in adversity. Very few people can do that, though, I think, Dr. Eder. But thank you for your question.
Thank you.
Thank you. And Shanna, can I have you unmute and maybe ask your question?
Sure, thank you. So my organization has a large number of certified peer specialists on our staff. They mostly take our warm line calls. And I just wondered your thoughts on helping staff build and develop resiliency, given extra consideration that they are living with a mental health condition as they work in the mental health field.
So I think resilience, when I first started doing my research, it was, as evidence I'm not the smartest guy around, I spent most of my career treating post-traumatic stress disorder, not thinking that perhaps we should be trying to prevent it. But finally, I figured that part out, better late than never. And one of the things that my colleagues would say is, George, I think you may be wasting your time. Resilience is born, it's not taught. Well, but isn't that a researchable question? I mean, shouldn't we make that an empirical question rather than an opinion? So that's what we did. And we found, very similar to the famous adoptive twin studies, is resilience innate or is it teachable? Yes. I say that with great confidence. So it's both. The question is how much. And I would say, what's the weighting? What's the ratio? It probably varies from person to person. But the good news is that a significant amount of the variance is acquired. And as soon as you say that to me, a psychologist, I'm giddy. Because now all I have to do is find the formula. How do I do that? And those formula are there. So we have indeed been able to teach people to be more resilient, especially the people that we put in harm's way for psychological injury. Are there certain professions that are at higher risk for psychological injury? Absolutely. And healthcare is one of them, is it not? So I would go out on a limb and say, if we are going to knowingly put people in harm's way for psychological injury, do we not have a moral obligation to prepare them to do that? Now, here's the good news. We've found, and we've tried variations on themes, but we've found that we can basically teach, in fact, we even have a little course called Psychological Body Armor. And we can teach that in hours, not years. The acquisition of the skill comes with repetitive practice, obviously. We plant the seed. If the organization, however, fosters it, supports it, then we find it's easier to acquire the skill. So I'm really quite optimistic that we can teach people to be resilient. When we teach mental health clinicians of any ilk, counselors, psychiatrists, psychologists, one of the first things we should teach them is about countertransference reactions, shouldn't we? That providing health care, mental health care, can be stressful. The failure to do that and the failure to prepare them, I think, is an egregious act of negligence.
Thank you, Dr. Everly. I think we have time for one more question. and I have one that I'd like to ask. So I'll let somebody chat in if you need to. But I guess, given your history of working in several pandemics, I'm curious, and maybe we can end on a bit of a hope here. You say that this is very different. Maybe you can give us a concern of why it's different, so something that you think is concerning, but maybe something hopeful that you found through the process.
So I developed a formula for being able to measure relative toxicity, psychologically speaking. And the formula is very simple: mortality and morbidity, interacting with duration, interacting with ambiguity around the phenomenon itself and messaging. And the fourth factor is resilience. This one is the most toxic I've ever seen because it is high on the first three and low on the last one. We use the term social distancing. I think that's a mistake. We should use the term physical distancing. We know the single best predictor of human resilience is connectivity to others. So we should not be social distancing. If anything, we should be bringing ourselves closer, but thinking outside the box on how to do that. The hopeful note is that this has forced us to think outside the box. This is a time, I think, it's a somber moment, but this is a time, I think, to rekindle old friendships. It is a time to bury old hatchets. It's a time to reach out in three-dimensional cyberspace through text messaging, through Zoom, rekindle relationships. It's actually easier now. I have a friend who every Tuesday would get together with her friends and go out to dinner. So you think that ended, right? No, they do a virtual dinner. They get together at the same time. They bring dinner for each individual person, but there's 6 people eating dinner, 6 different places, but they keep the connection alive. I think we're going to come out of this better.
Fantastic. Well, I think you're right. And so we'll end on that note. Really appreciate you coming to join us. And certainly please reach out to us or Dr. Everly if you have follow-up questions. He is the expert on PFA. So certainly if there's things that your organization feels like you need to improve, he is the main resource for that. So thank you so much for joining us today. I'll be mindful of time. Just quick reminders: on 2 weeks on Wednesday, we'll have Dr. Susan Scott from Missouri. And then on the 9th, we'll have Dr. Jonathan Ripp from Mount Sinai. And then all who know me know that I'm really into memes. I'm like 5 years behind the rest of the world. So this is new to me in COVID. So thank you, COVID, for introducing me to memes. But these were the ones that on my Facebook group were funny to me this past week. So wanted to share it with you. And Dr. Everly, I know we were talking about Zoom fatigue. So I feel like that one struck me and just kind of made me chuckle. So thank you everyone for joining us. So glad to have you. We hope to keep the connections, keep the network, and I guess as Dr. Everly is pointing out, keep the friendships. So take care everyone. Have a good 2 weeks and we will see you August 26th. Thank you so much. Thanks, Dr. Everly.
Thank you.